Now it is my pleasure to introduce the presenters for our general session this morning. The American Pathology Foundation, our collaborating society partner, has put together an enlightening program with experts who will help us anticipate what regulatory, compliance, and billing changes are coming and how we can manage our practices most effectively amid this disruption. Dr. Alfred Campbell, immediate past president of the American Pathology Foundation, will moderate our distinguished panel for this scientific general session titled Evolving Pressures on Laboratories in 2014 and Beyond. Please join me in welcoming Dr. Campbell to the platform.
Good morning. Welcome to today's general session sponsored by the American Pathology Foundation. Evolving Pressures on Laboratories and Pathology Practices in 2014 and Beyond. I'm Dr. Alfred Campbell, the immediate past president. As was already stated, there's a little confusion there. I was president until about a week ago. I'm the immediate past president now of the American Pathology Foundation. My day job is a usual APCP private practice physician in Spartanburg, South Carolina. I'm a member of the Carolinas Pathology Group. It's a group of approximately 30 physicians and PhDs that cover not only Spartanburg, but also the Charlotte, North Carolina area. I'm also president of our independent anatomic pathology and cytology lab called Celligent Diagnostics. The American Pathology Foundation is an organization of pathologists and pathology practice managers that focuses on providing education and sharing knowledge on practice management issues involving laboratories and pathology practices. For those of you who've been in pathology and laboratory business for a number of years, you may remember or have heard of some of the significant challenges we've had to deal with. There was the introduction of Medicare. There was TEFRA in the early 80s, which changed the way pathologists were paid. In the late 80s, we had CLIA, which changed the regulatory environment that we work in, and is still with us today. Now, all those challenges came at a time before I was active in pathology, and maybe before many of you as well. I've been in practice for about 16 years. First half of my career, I sort of consider those the quiet years. You were able to go to work, do your job, get paid. While I believe I was doing a good job in putting out quality results for patients, I didn't have to prove it. Seems the last 5 to 7 years have been significantly less quiet in pathology. Sometimes I feel like in a perpetual game of whack-a-mole. Every time something to take care of is 2 or 3 more things pop up. It's like we're on everyone's radar screen now. There are regulatory challenges, there are reimbursement challenges, there are professional challenges. So what's driving these challenges? You can probably come up with a number of reasons yourself. But for me, I believe there's primarily 2 main drivers. Financial. I think most people believe that the current healthcare model is probably not financially sustainable. And quality. Among the top industrial countries in the world, the US fails to show better outcomes and is near the bottom in access, efficiency, and equity. So what are some of the challenges we face? There's a whole number of challenges, but what are a few? There have been a number of payment reductions for fee-for-service pathology, including revalued codes. And surprise, surprise, they almost only go down. In 2013, there was a significant decrease of more than 50% in the technical component for our most common code, the 88305. In 2014, prostate biopsies of 10 or more units were combined into 1 unit of service. Now for 2015, CMS has recommended that there should be only 1 unit of service no matter how many prostate biopsies there are in a patient. Also in 2014, immunostains saw significant decreases for multiple different stains on the same specimen. And once again this year, CMS wants to figure out a way to tie pathology services to the OPPS, the outpatient prospective payment system. So guess what? They can cap payments at the lower levels of the OPPS. Speaking of the OPPS, there's also a push to bundle clinical lab tests in the OPPS rates. By the way, bundle is payer speak for less money. CMS also wants to revalue the tests on the clinical lab fee schedule. In the Preserving Access to Medicare Act passed this year, CMS was given the authority to have labs report median prices for each test to set payment rates. Which labs will report? How will they report? It's all unclear. And how will they use the data to set the rates? The FDA is working on regulating laboratory-developed tests, and exactly what impact that will have is still unclear. There are concerns about immunostain usage, and recently Palmetto, which is a Medicare intermediary, put out a notice, sort of a local coverage determination, but not really, that tried to set expected usage levels for Helicobacter pylori immunostains. Now they've hired a contractor to compare pathologists against each other within their state or region on immunostain usage. There is PQRS, the Physician Quality Reporting System, which requires reporting on those measures a pathologist can report on, or face a decreased payment for all Medicare patients. In addition, most pathologists report in a claims-based way, but that may go away so that everyone has to use a registry method, which will likely include additional costs to report. And now as we deal with PQRS, we're also trying to understand what the impact of the VBM will be, the value-based modifier. The value-based modifier tries to compare physicians to other physicians in their same specialty, thus creating winners and losers. In other words, some will get paid more for the Medicare patients, and some will get paid less. What's the impact of patients having ready access to their test results as required by HIPAA? Then there's ICD-10, which has been put off a couple of times now, but theoretically it's less than a year away. What kind of impact will that have on practice? There are still some pathologists that do not receive Part A or only token payment. Of course, that's been a problem for a while, and it's kind of fallen off the radar screen a little bit because everything else has popped up. What about disruptive technologies that may have an impact? In vivo microscopy, ex vivo microscopy. They could completely change anatomic pathology as we know it. Maybe some of you heard, what about Theranos and their lab testing platform? Will that impact laboratories in a negative way? Now that HPV testing has been approved as a primary screen, will Pap test decline significantly? Oh, yeah. And there's this little thing I forgot to mention, ACOs, accountable care organizations. What will they have? What kind of impact or effect will they have on labs and pathologists? And talking about ACOs brings me back to what is driving these challenges: finances and quality. ACOs are focused on both of these items, which for me, taken together, finances, quality, is value. And ultimately, that is the goal of all of these challenges we face. Better quality for a lower cost, value. I don't want to give the impression that we only have challenges. It's very short-sighted. With every challenge, there's an opportunity. An opportunity to grow professionally, to impact the top line and or bottom line of the organization, to create efficiencies, to better deliver patient care. In other words, create value. We need to learn that uncertainty is an opportunity and not just a challenge. We have to be an active part of the healthcare team and continue to do what we do, be leaders in quality. We have to learn to be more vocal about our value to the healthcare system. This is not rocket science. It's pathology and laboratory medicine. We got this. So now that I've scared everybody half to death with all these problems, we're going to have a couple speakers come up here and hopefully talk about some things you can do to help with opportunities for some of these. The first speaker is Dr. Michael Talbert. Michael is the Lloyd E. Rader Professor and Chairman of Pathology at the University of Oklahoma Health Sciences Center, where he also serves as the Director of the Residency Training Program. Prior to coming to Oklahoma, Michael was the president of Dahl Chase, a private practice pathology group located in Maine. Michael is a past board member of the American Pathology Foundation, and with his background, Michael is well-versed in practice management and financial issues. Michael?
Thank you very much. Dr. Campbell, thank you for that nice introduction, and good morning, everybody. So I'm here with a pretty simple message. We've got change in the air, we have challenges that we're facing. You need to take time and devote resources to creating the best future you can for yourself, for your practice, and for your laboratory, and hopefully through this process, maybe shape the future. And I want to spend about the next 10 minutes talking about how I think about the challenges and how you might take some of these ideas and turn them into action plans. And I don't have this talk just for the leaders in the audience. You know, people say, hey, he's a chairman of the department, he's just going to go and tell people what to do, and it's all going to happen. Well, no, this is designed for everybody, because I know that each of you, as dedicated, well-trained laboratorians, you, A, care about your job, B, care about your laboratory or hospital, and most importantly, you care about the patients that we serve. So each of you needs to be part of this thinking and acting process. And maybe in contrast a little bit to Dr. Campbell, I sometimes refer to myself as the optimistic pathologist, because I really think that this is an exciting time. I've often been troubled, I've been in pathology now for about 25 years, that even though we're a rich country, we're so lucky to have all the resources we have. We actually have the best healthcare in the world. We just don't necessarily evenly apply it. But we need to take those resources and best apply it, and then go on to focus on the combination of value and outcomes. And that's what we've not really done in medicine. And to be part of that is a really exciting opportunity. So with that being said, I'm going to spend about the next 10 minutes talking about how I sort of think about the challenges and maybe encourage you to think about the challenges, and then where are the opportunities and where you might move. So we know about the challenges. We have new payment schemas, new structures that are coming up. We've got value-based purchasing. We've got bundled payments. Those actually come with additional transparency, and that's kind of a scary thing for us to think about. We are now either parts of larger and developing systems, so we're either insiders or we're outsiders. We're purchased services. Think of maybe a reference laboratory or something like that. If you're an outsider, you've got lots of independence, but you're a purchased service. You're actually maybe seen as a commodity. If you're an insider, well, that's great, except you don't really have the independence you might have had before. You're part of a bigger organization, and you're actually subject to the success or lack of success of this larger organization. So it's really an interesting time that way. And as laboratorians, we know we add lots of value. We add value with most everything we do. But there aren't that many schema for paying for that value, and we've really not done a very good job of measuring the value and explaining it to others in our healthcare environment, particularly the decision makers and the people who will actually give us the resources in the future. So for instance, in our microbiology lab, we deployed a new test, this was about a year ago, where we actually projected we would save, this is for our children's hospital, about 81 days of inpatient time by more rapid diagnosis, which would allow a rule-out protocol to complete and the patient to go home. 81 inpatient days. This is in a children's hospital that's essentially always full. I mean, incredible value to our community. We now have the ability to take care of more children who are very sick. And then we look at these exciting new frontiers. it's not really clear what to do with those. I mean, where do those fit in each of our practice models? We heard yesterday from Dr. Mesko about next generation sequencing. We look at the area of genomics. The cost of it's going to, well, almost zero, to where it might be more expensive to move the specimen around than it is to do the testing. How does that fit into our practices? You know, before we were thinking, oh gosh, where are we going to find $500,000 to start doing next generation sequencing? Well, I'd say turn the equation around and ask you, okay, how are we going to add value? I mean, the value may start just right in your own laboratory where, okay, which specimens need to get tested? You know, where can we add the value and pick out the correct specimens and make sure the right thing happens for the patient? Digital pathology. I was in a digital pathology discussion yesterday afternoon with Dr. Pantanowitz, and question at the end was, how do we make the case to buy all this stuff? I mean, you're talking, $50,000, $100,000 to deploy a system like this. And his answer was, well, I can give you a nice example. There's a hospital where they provide neuropathology service by frozen section using digital pathology in another state. And that keeps that hospital from needing a neuropathologist, and potentially they could hire a neuropathologist to sit in the hospital all the time, or they'd hire a neuropathologist who'd be there on frozen section or on days when they might be doing neurosurgery. So incredible way to focus expertise over a distance. Very efficient, with much better outcomes than you'd have with potentially a general pathologist was there to maybe triage the case, glioma, not glioma, and do it that way. We have all these other IT things that are happening. We learned a lot about social media yesterday. Patients have access to their own reports. I think there's only 5 people in this audience who aren't carrying smartphones, and 2 of them just blushed. I mean, you've got at your fingertips 24/7 much more knowledge than any one of us has, and we're the experts. I mean, that's an incredible paradigm. And then population health. We're used to taking care of patients one at a time. When they get sick, they come to us. And unfortunately, our profession kind of holds this, well, we also take care of the dead people. But no, we're looking at keeping our entire communities healthy. Preventive medicine, wellness, remove disparities. What's our role there? How do we add value? We have incredible testing. We've got all kinds of information. We're probably the best at informatics. How do we project? So I think these are really interesting challenges. We could spend an hour on each one of these. So what to do? So I want to step back and give you a couple observations on change in healthcare. The first is that, in my experience, change in healthcare at best happens at 1/3 of the pace you think it should. It just doesn't happen fast enough. So we saw yesterday morning in Dr. Mesko's talk about a little device, kind of looks like a bovie that a surgeon could use to test tissue to see whether it's benign or malignant. And all of a sudden people saying, oh my gosh, well, we won't need to do frozen sections. That'll all go away. How many people are going to go back on Monday and sell their cryostats? Well, nobody. I mean, what are the chances this actually makes it to sort of ubiquitous use? Don't know. But again, something you should be watching, but the change comes very slowly. I mean, more coming home to us in what we do and taking care of our populations, we know what to do with certain cancers, what kind of molecular testing they need for predictive markers, how they should be best treated. We've got great national agreement on what to do, and yet surveys would suggest that's less than half of patients that get the appropriate testing and the appropriate treatment. In fact, in one study, it was perhaps as few as 10%. I mean, what we know to do, we can't bring the change in. So it's slow. The other part about change is that it happens in fits and starts. And it also has geographic variations. What may be happening in Alabama could be very different from what's happening in Oklahoma. What's happening on the West Coast is clearly different from what's happening in Oklahoma. So there are all incredible geographic variations. What this means is the transition's very uneven, both in terms of the speed of things, how things pace themselves over time, and then how it actually happens in your neighborhood. You may skip 3 years of transition that your friends are experiencing 2 states over. I mean, a very different background to change in healthcare than what we're used to, which means don't panic. Now, it's possible that you're already sitting in a place where the steamroller's bearing down on you. You just happen to be in the wrong place at the wrong time because you're being affected by that change. Okay, that may be true, but there are plenty of other people in this room where you sit back, okay, I know this stuff's coming, we're thinking about it, we can do this. So again, the change is a very interesting part as we go through this transition. It's just going to be very variable, which means you really have to pay attention to what's going on and tap your network, talk to everybody, find out what's going on in their neighborhood and what they're doing. So one other piece of sort of let's sit back and observe things is what I call the tale of two viewpoints. We're healthcare providers. We work inside the healthcare system. We're expert laboratorians. We see our system as sort of evolving to get to a new place. If I sit on the outside, if I sit there maybe as a venture capitalist, a serial entrepreneur, or maybe a vice president at Google, I sit there and go, holy cow, that healthcare, I mean, the model is just, it's so far behind, it ought to be extinct. We should see mass extinction in healthcare providers. We should be able to go in there and do all kinds of things. You know, I used to really worry about that 15 years ago when I first started thinking very broadly in healthcare. But you know, why hasn't Walmart taken over healthcare? And why hasn't a single health system like the Mayo just all of a sudden, you want to hear from the Mayo? Just developed a better mousetrap and all of a sudden everything is the Mayo. Well, it just hasn't worked that way. So more to the model from the inside is what I've seen, and I've been in pathology about 25 years, is, and I'm going to take surgical pathology, is we've kind of gone from general surgical pathology practice, everybody doing everything. We've become subspecialized, and I know there's a bunch of residents in the audience, and most of you folks are going to do a fellowship in some area of anatomic pathology, so you can be somewhat specialized, because that's the direction things are going. This has been an evolution over time. If you go back to when Dr. Alexander trained, fellowship was a pretty unusual thing. You might have talked, you know, a famous, world famous pathologist, and he'd take you on as an assistant for a year, so you could kind of watch the master at work, but you know, fellowships just didn't really exist. That's a relatively new thing. And then in terms of our business structures and our practice structures, those have become much more sophisticated. We have marketing, we've got consultants coming in, doing lean projects with us. We now, I think the example I like to look at is we now have venture-funded subspecialty companies out there that exploit certain niches of healthcare because while they're sitting there looking at that area is kind of ripe for the picking or extinct. And then sitting there from the outside, okay, healthcare is resistant to change. It changes much slower than you think it should. We have outdated systems in IT. I mean, FedEx can track a package around the world. I sometimes can't find a specimen in my own hospital. Yeah, I hear laughter. So that's confirming that it's not just my place. We're fragmented. We take a cottage industry approach to everything, and we love for each of our institutions to reinvent the wheel, just in case it comes out different. Anyone come up with a square wheel yet? No, it all comes out about the same. So what I like to really think about is that this is our time to put ourselves in the middle. Start thinking more like an entrepreneur while we're on the inside as healthcare providers. And I think you want to be somewhere between evolution and extinction, and I think right there is the place to be. So more graphically, evolution is sort of a straight line, gradual process that I've enjoyed that for 20-ish years of my professional life. And then we're under a lot of pressure now. So what happens with evolution when it comes under pressure? Well, things begin to diverge. You start to see a few people continue to evolve in the same pathway. Occasionally you'll see splits in the development, and you see, well, some extinction going on as well. So there's some demise that goes on. But what really happens when things pick up, and I think this is kind of where we're at right now, but as things continue to pick up, you start seeing new life forms. And that's where I want us to focus, is start thinking about the new life forms. What I want you to do is to be thinking, okay, I got to keep evolving. It's okay to diverge, but I also got to be thinking about creating new models and new things. And these can be somewhat experimental. You know, I wouldn't sit there and have everything be a leap to a new model necessarily, but this is what we have an opportunity to do now. And in this time of transition, and we've talked about how it is a transition, continue to do what you do and do it well. The transition will be sort of slow and gradual. For some of you, it will be faster. For some, it may never truly occur, and you'll still sit in a somewhat fee-for-service environment for 10, 20 years. Who knows? I want you to evolve as you have been, diverge if necessary, and experiment with the new models. So if you're thinking as an entrepreneur, okay, they're always worried about how do I get capital, where do these resources come from, et cetera. Well, historically, we've just relied on our hospitals. They've had deep pockets, and gosh, we're hospital-based for most of us, and they say, hey, I could use a little money to try this out. Okay, let's do that. Let's keep Dr. Talbert happy. Or maybe they'd ask for an ROI, and you dream up something, and then you just got to sell it to them. That's great. Not so true anymore. Hospital margins are under pressure. So you got to get a lot more creative in where these resources come from. But it still is. It's time to think and invest in new ideas. You need to take time first. You guys, I'm sure you've heard the joke about if you're not at the table, you're probably on the menu. That's even more true now. In fact, there are a lot more tables, and they don't even tell you where the tables are necessarily. There might be a group back at your hospital talking about getting involved and starting an accountable care organization. You need, or somebody from your area of influence needs to be at that table and involved in those discussions. You have to be more aware of your own environment. So that's true. You need to spend more time learning, looking at what's new, talking with other pathologists, find out what's going on in other places, talking to your laboratory friends in other places, find out what they're doing. Much more investment in those kinds of things. Then they begin to experiment with little models. Take small steps, see what works. And if you look at the challenges, they all focus down, as Dr. Campbell points out, to adding value. Always think about, how do I add value? How do I add value and then show it? So what I'm doing in my own environment is I'm spending more time going to meetings. This has been a great meeting. I've got 2 pages of ideas. Most meetings I only get 1, and that's been really, really, really nice. Give me some things to think about. I'll talk to other people about, maybe try something. That'll be good. I spend more time networking. I spend more time on the telephone, just calling people up to chat with them. People call me, and that's been very good. I spend more time with my media. So I get a lot of different media feeds. I just quickly glance over and see, hey, what's new, what's going on? And that works very, very well. The other thing is to begin to experiment. So I got 3 experiments I'm going to share with you. My first experiment is I have a young pathologist who's very good at tech. And I've kept him on as an instructor in medical innovation to go around. He can walk into a situation and program a solution like that. It's unbelievable. And we're actually looking at turning some of that stuff into intellectual property. I had a person interview for a position in our molecular pathology laboratory as a technologist. Incredibly skilled, had actually never worked in a clinical laboratory before, which was kind of interesting. And her skills were so incredible, we actually brought her on as a project manager. And about a quarter of her time is spent working with our clinical pathologists to define and measure the value that they're adding. And then finally, my third thing is that I'm actually hiring ahead right now. I'm hiring people I don't actually need to get the work out with the idea that I can bring in more ideas right now. I can free up my other people to, again, get into some of these new models, spend more time thinking, and that allows us to move ahead. So that's what I'm working on. For you, your situation is going to be different. And how change hits you is going to be different, but I would encourage you to just take some basic ideas and fast forward. What happens when everybody's got a smartphone? What does that mean? What happens when the next generation sequencing becomes ubiquitous and cheap, and that little jobby you can plug into your computer was pretty amazing? What happens there? What unmet needs or unknown needs are around you? What's possible there? We happened to merge with a small hospital that didn't really have much hematology coverage in terms of an internist or a primary care doc who was interested in that area. So if they had a patient who had anemia, they all got referred to hematologists. So what we're doing now is we consult on those patients. And we actually do most of the simple anemia workups and keep the patients from being referred. Do we get paid for it? Not particularly. We get a smear review out of it. On the other hand, is it valued? Oh, you betcha. And a lot of these patients don't get referred because a lot of them are actually getting referred out of our system. 3 terms, just Google them, think about them, put them in your box. Think about where we add value and how they'll impact your practice going forward. So my final message for you is maximize the present, but think about the future. Go out, start experimenting with new models. Think like an entrepreneur. Some of your models will fail, but it's very possible that some will be very successful. And then finally, we're going to have some questions at the end, but I'd like to invite anybody who would want to. Always feel free to reach out and pick my brain. I learn a lot that way, and I'm easy to find. Email, call, whatever. This is a very exciting time. We're creating a future healthcare delivery system that, well, we're going to all need, but we'll really feel good about and will better serve our population.
You've been cut off. Thanks, Michael. So, you know, obviously after hearing the talk and knowing you for quite a number of years, I really could sort of categorize you as an optimist. I wouldn't categorize myself as a pessimist. I guess I would categorize myself more as a realist with optimistic features. So, you know, but I guess, so my question to you is, okay, so you gave us the optimistic spiel here. What one challenge keeps you up at night? What are you most worried about what you see occurring in pathology and laboratory medicine today?
So I'm part of a healthcare team. My laboratory's healthcare team, all the pathologists, my faculty healthcare team. I'm part of an 800 provider faculty practice plan. We're all one team. I worry about bringing the team along. I mean, everybody's got to feel comfortable. We have to all be moving ahead. And I worry about people either sort of, oh, I don't know what to do, or worse, that people will begin to panic and start doing things that make no sense. That's to me, is the hardest part, is the people part and bringing everybody along. I mean, I do think we're headed to a better future. I do think there are disruptions. And there will be people who find themselves looking for new jobs and such like that. But to me, it's the continuous education of people, bringing people along. So for a lot of the, when I like to sit and think about things, a lot of times I'll be talking with small groups of people, and let's just throw these ideas around. Maybe it's over lunch, maybe it's after hours, and so again, trying to bring everybody along. So that, to me, that's the most challenging thing, is we have to all come along as a healthcare team.
Okay, well, thanks, Michael. And so at the end, Michael and Jane will be out here, and we can take a few questions if you have any questions you want to ask later. Our next speaker is Jane Pine Wood. Jane received her law degree from Vanderbilt University and is currently a member of McDonald Hopkins law firm based in Massachusetts. Over the years, Jane has become a nationally known expert on regulatory, reimbursement, and contractual matters related to laboratories and pathology practices. She's been a regular presenter at American Pathology Foundation meetings for longer than I can remember, and is on my speed dial. And not just because she's a fellow Texas Aggie. Jane.
Thank you, Dr. Campbell. What I'd like to do today is follow up on the presentations that Dr. Campbell and Dr. Talbert have given. Dr. Campbell talked about value. Value being the quality of the services tied together with financial brought together. Dr. Talbert talked a lot about the quality and how the quality plays into the value proposition. What I'd like to do is take some of the financial part. From my perspective as a lawyer, what are some options you can consider from the financial standpoint to try to bring to that value equation? I've also been listening to Dr. Talbert. He talked about evolution. And for those of you who've heard me speak before, no, I don't usually use PowerPoints, in fact, hardly ever. But I'm going to evolve and use some PowerPoints today. First question, in terms of what, clients are often asking, what can we do to better position ourselves going forward in the future, given all these challenges? And for me, from my perspective, looking at things from a legal side, the financial aspect is key. If you don't get paid for what you do, one, you can't stay in business, but you also can't grow the business. You can't move things forward, and you can't bring the quality to the table if you don't have the money to pay for what it takes to bring the quality to the table. So a lot of my work is focusing on the financial aspect. So one question from a lot of clients is, is bigger better? We're a small pathology practice, we're a small lab. What can we do, and will it help us to get some critical mass in dealing with the challenges? From my perspective, in most cases, not all, there are always exceptions, but in most cases, there's an advantage to having a critical mass. Bigger often is better in dealing with the challenges of this world. So what are the ways you can come together? Now, each of the things I'm going to talk about could themselves be the subject probably of an hour talk. So unfortunately, I don't have time to give you a lot of details, but I'd like to do is give you some ideas to think about. And certainly, if any of you have any questions about them in more detail, feel free to give me a call, shoot me an email. I'm going to go from least formal to most formal with some of the pros and cons. A lot of you probably already have what I'll call the informal handshake arrangement. You know, this is where you have another pathology practice or another lab, and you work cooperatively together. Perhaps it's people you trained with. If you have gaps in your service coverage, you'll often refer the cases to the other party because you know they're going to watch your back. They're not going to steal work from you. If you need locum coverage, if you just need general support, if you have someone you want to bounce ideas off of, as Dr. Talbert was just saying, you know, picking up the phone, talking about ideas and what can we do to go forward. You know, that's the informal arrangement, and that makes a lot of sense. But does it get you to, say, working with ACOs? Does it get you to working and coordinating with payers? Likely it doesn't. It may help your practice, but I'm not sure it really helps you with a lot of the challenges coming forward. So how do we go down the integration scale? And where are things, if you so choose, to move to have more critical mass? The second step would be some type of formal contractual relationship where you decide, here's some things we can do to each other, but we want to formalize it a bit. You know, for example, we want to have a formal referral reference lab relationship where we're going to buy services that we don't provide from the other party, for example, and bill those. Or, you know, we have turnaround times and we have very dedicated rules that we're going to follow in this relationship. You might have something that's more formal for locum coverage. A shared courier, shared marketing. I see this with a number of our clients where one group may be more focused on AP, another one may be more focused on clinical lab services. So you're not competing against each other in the same marketplace. You're providing complementary services. Why should you each duplicate efforts with marketing force, with courier services, if you can combine those and work cooperatively together and share those through a contractual relationship? You may have some shared services, maybe some shared billing and collection or other administrative services. Those are all possible to do. And they certainly help you from a bottom line standpoint in that they're going to help have more efficient operations. But where's the downside? You still can't go and contract collectively with a third-party payer. You're not integrated. You're two separate practices. From an antitrust standpoint, you have a lot of limitations. Competitors, people in separate practices, can't go to a third-party payer and say, hey, we want to come to you and we want to be paid, you know, 120% of Medicare for our services. That conversation you can't have. On the other hand, if we go forward and look at a more integrated model to see, you know, what can we do to get forward a little bit more. The next would be what I call a network of pathology practices. Again, you're still independent practices, but you decide to come together in what you'll market to the public as a network. Usually this is, when we have this with clients, is they look at a geographic area and they say, you know what? We may each be small individually, but we could really cover a huge geographic area if we come together. That can be very attractive to third-party payers. I know for many smaller pathology practices and laboratories, particularly if they're in the outreach market, trying to gain the work in the outreach, it can be a real struggle just to get in network, you know, much less have good payment rates. But if you can go to a third-party payer and say, you know what, we can bring services. We can offer one-stop shopping to your subscribers in this area. You know, we would like to be the network for pathology. That's an advantage. It gives you a foot in the door, much more so as that group than you would as the individual practices or even under that, you know, looser contractual model. For most of these networks, you're not going to be integrated enough to jointly negotiate the fees. You may be able to go together and get the foot in the door with the payer for the payer to grant you a contract. But unless you have really integrated billing and collection, a lot of shared overhead where you really are sharing risk within each other. Now, if you have some risk-based contracts, we can have a different discussion. But in many of these, it's still a little bit too loose to really get in there and negotiate fees collectively with a payer. So that's the downside of the model. In terms of the most comprehensive model from a legal standpoint that gives you the most flexibility and also just in the marketplace gives you the most strength, and that's a fully merged, consolidated model. Now, legally, there are lots of different ways you can structure this. I mean, we can have one side acquire all the other parties. We can have what's called statutory merger. Everyone sort of gets melded together in a pot with one survivor. The key is, regardless of the legal model involved, Here I'm talking about one tax ID, one Medicare group number. We're talking one legal entity. Now, revenues can be divided up in cost center areas. We can certainly have some autonomy, but I am talking about a model where you have significantly lost your autonomy as independent practices. You now become one practice. You may have separate cost centers, you may have different sites, but you're one practice. And that's a pretty big, I mean, most physicians are independent people, and do you really want to give up the independence and the control you have over your practice? Well, it may be worth it to position yourselves for the future, because what does that get you? One, if you're a larger integrated group, you have more bargaining power with your hospital or the health systems generally. You're a bigger group, you have more subspecialty expertise, you have more to bring to the table. The health system, particularly if it has multiple hospitals, because we certainly see consolidation among healthcare providers, that you offer a more comprehensive solution to covering an entire health system. If all the pathology practices within a health system have come together, what it does mean is the hospital's health system may not be able to pit one of you against the other of you separately. If you're together, you're one. With third-party payers, you're now one. You can go into a third-party payer and say, we're not just a small group of 4 or 5 pathologists, but now we're a large group of 30, 40, or 50. That gives you a lot more presence in dealing with a third-party payer. One, to be in network, and two, the leverage for the payer contracts. And that's significant. And in terms of just marketing to the public, attracting new pathologists, and there's lots of advantages. Clearly, I recognize this is an expensive option. It takes a lot of planning. Culturally, it has to be a good fit. You obviously can't be doing business with people you really don't like, and if you can't meet common cultural ideals in terms of how you govern yourselves, what your visions are for the future, it's not going to work. But if you do have the right fit, I think consolidated larger practices does position you well for the future from the financial aspect in dealing with hospital contracts, third-party payers, ACO networks. Next, we're moving really to the payer strategies, because again, as I said at the start of my talk, the financial aspect, if you don't have the money, you can't provide the service, you can't stay in business, you can't provide the quality. So the money matters. And unfortunately, sort of a crass statement, but that's the way it is. If you're looking at dealing with third-party, this is really focused on third-party payers, but a lot has to do with hospitals as well. Look at where are your leverage points. Where do you have strength? Now, obviously, the larger you are from most of these points, the more influential you can be. Your hospital may be a very good source of support with a third-party payer. It may or may not be. But if your group is integral to the hospital, if you have a lot of subspecialty expertise that the hospital depends upon, you can easily go to the hospital and say, listen, if we're not getting paid by these payers adequately, we can't keep this level of subspecialty expertise. If we're not in network, our outreach work is going to drop off, or we're not going to be able to expand it. And if the hospital's doing the TC on the outreach, that's a loss of revenue to the hospital. It's in the hospital's best interest to make sure you're in network for outreach work if they're benefiting from the TC. Employers, I find particularly for clients of mine who are in smaller rural areas, particularly if there's some larger employers, this can be a good push point because most employers, particularly if you have a larger employer in a smaller area, they like to buy local. I mean, most people do like to buy local. If you can go and say, we're local, we're here, but you know what? The payer you've signed up your employees to have their coverage with, they require all the lab work to go out of state to some national lab. What pressure can you put on that payer if you're going to pay all this money in subscriber premiums to have some of that work stay here locally? The same argument works with local legislators. Your taxpayers, your citizens, your employers in your community. You are key to the economic vitality of your community. If you have a payer in the state or in the region, particularly a nonprofit, who again is keeping you out of network or not paying you a living wage, to go to your legislators and say, you know what, this is really important for us, for the community as a whole, and for the tax economic job base of our community, for us to be paid well. What pressure might those legislators put on a licensed insurance company? Again, remember, insurance companies are licensed by the state. And if they're nonprofit, they also have some obligations to the community. Also look at where you might be a sole source of medically necessary services. I have clients who've been out of network. You know, the payer has a large national lab as the exclusive provider, but locally we look and say, you know what? No one's doing frozen sections in the surgery center except us. Or maybe there's some other services you're providing that that national provider doesn't have. That can get you a foot in the door to talk to the payer to say, listen, we have something to offer in this community that's vital. Because remember, the insurance companies have to keep a valid network for their subscribers. And certainly, as both Dr. Campbell and Dr. Talbert have said, if we start looking at the changes in payment, if we look at the ACOs and the shared savings models, a lot of focus on cost-effective quality care to keep patients healthy. You know, again here, if your local services can better provide that and keep patients healthy, that's a good value proposition to the third-party payer as well. Another option some people are looking at, it is legally more challenging, but I think it's certainly worth bringing up in terms of the laundry list of things to consider. If you're out of network, or maybe you're the in-network provider, but you have other out-of-network providers you want to assist, or particularly if you're out of network and how do you get in-network, one option I increasingly am getting calls from clients about is subcontracting with a participating provider. Someone has a contract, can we simply provide the services, they subcontract and they bill for our services? The answer is sometimes yes, sometimes no. You know, a couple of legal issues. We have some fraud and abuse issues, we have to worry about how we structure payments. We have to be mindful of Medicare and Medicaid billing rules of when direct billing would be required and when billing for subcontracted services is permissible. As you know, many states have direct billing laws or anti-markup laws that may come into play. We also sometimes have payers who have very restrictive language which may not permit subcontracting. But it is something you may wish to consider if you find yourselves out of network. This is really another kind of alignment. I mean, jump back to the first part of what I was talking about, you know, is bigger better. You know, this is another way to sort of try to get at that idea to align and become part of something bigger. Again, you really have to review these options with your advisors because there can be a lot of legal challenges. Conversations with third-party payers. You know, whether for better or worse, what are we dealing with from a payment standpoint now? ACO, shared savings. The idea is keeping patients healthy at a cost-effective rate. Beacon LBS, obviously a huge topic of discussion these days. But what is the value proposition there from Beacon LBS? Going to a payer and saying, listen, we can manage the pathology laboratory costs. My proposition is you can do it better. And the payers need to hear that. Capitation, you know, capitation is sort of an ugly word, but whether or not we like it, it is part of the bundled payments that payers are looking at more. So if you start to look at what we have as the payers, I mean, this is on the payers chart. The shared savings, the Beacon type of model, the capitation, the bundled payment. Think about how you can propose payment options that then rest upon your strengths. Whatever subspecialty expertise you have, you're local, you know the clinicians, who better than you, who better than the local pathology provider can work with the attending physicians to make sure there's cost-effective, good patient care and quality. How does that happen at a distance? That happens locally. Play upon these strengths, but you may want to think about how you work them into some of these payment models, because again, this is what the payers are going to be looking at from their value standpoint. And with that, I think my time is up, and I'll turn back over to Dr. Campbell.
Thanks, Jane. So, a couple questions. One is, as I think back during my quiet period, like I mentioned, you know, we didn't really worry too much in the laboratory business and pathology about the legal ramifications of a lot of things we did.
Busy either.
Right, and so obviously in the last number of years, things have really picked up, and everything now, it seems like everything has legal ramifications that we used to never worry about. I guess, you're seeing the same with people.
I am. And one thing I advise clients is you do want to be very careful about what you're signing now, because, and I'm working with clients, you know, we may not know where the world is going, but we know we need flexibility. And increasingly with third-party payers, I'm finding that clients may have signed contracts or entered into arrangements where their hands are tied a bit. Now, I recognize you may not have a lot of options, but my suggestion is, particularly now, if someone's giving you something or your hospital saying sign up, make sure you know the ramifications of it, because if you know the ramifications, you can better plan what you'll be doing in the future.
Okay, we're running a little behind. I'm going to ask Mike Talbert to come back out, and we'll take a couple of questions from the floor if there are any questions anyone would like to ask. And if not, this will be short and sweet.
My question's for Jane. I'm from the state of Florida, and Beacon LBS is an important part of our laboratory's life right now. We have a large outreach program, and we have had many discussions. United Healthcare, for those of you who aren't aware in the audience, is now using Beacon LBS, and we're being told that there's 81 tests. All the pathology tests are pretty much on that list, that we will not be paid for as an outreach laboratory if there's not pre-approval through the right process through this Beacon LBS physician decision support software. And so do you have any advice for our laboratory? It's difficult to not begin testing on specimens when they're received to see if we eventually get that pre-approval. So we're kind of stuck between a rock and a hard place.
Sure. It's an interesting model, and for those who aren't aware, United Healthcare has now announced that the claims processing penalty is now delayed until at least January 1st. But United Healthcare is still expecting clinicians to do a notification. And what the idea is, if you're a participating provider, lab, or pathologist in Beacon, you have to register in a system, so you're in a computer system. If you sign the lab of choice agreement, which is a separate agreement, voluntarily you can sign it or not. You don't have to be part of this, but you get paid lousy rates if you do. I don't think you heard me say that, but you know, that's what it says. But the clinician, within 10 days, for a surgeon does, you know, taking a specimen in a dermatologist's office, the dermatologist has 10 days that he or she has to go into the computer system, find the name of your laboratory, and put a notification in. That's separate from the order, because obviously the dermatologist would have had to place the order. Now he or she has to go into the system and do this notification within 10 days. If it's not done within 10 days, you don't get paid. And I've had conversations with Beacon too, and I know this is a conversation that will continue over the next several months with United Healthcare and Beacon. So what does that mean? The notification isn't made, the physician's gone to India to visit family for 3 weeks. Do you hold the specimen? Do you process it? Do you not report out the result? Beacon has said, well, if that happens, just appeal it. Well, I'm not sure United Healthcare knows that that's what's being said, because I think United Healthcare is going to be bombarded with appeals. For right now, my suggestion is talk to United Healthcare about the patient quality issues, not necessarily the financial ones, because I think financial somewhere else, but if you focus on patient quality and say, this is going to be disruptive to patient care in the following respects. This is going to be very difficult for surgeons and clinicians to implement. This is going to delay results, and this is going to impede care. That is the weak point of United Healthcare, because that's where they have their legal liability if they have a network and policies that are actually negatively affecting patient care. So I'd focus on the patient care angle.
Any other questions?
Question, sorry, for Mike or Jane or Al, and it has to do with the future, 2015. CMS's proposed bundling of provider-basing things. Anybody want to forecast how that's going to go?
Well, he's the optimist. He's sort of the realist. I'll be the pessimist, and I'll say I'm not holding my breath for it to turn out well.
I think long-term you're going to expect there's going to be more and more bundling prostates for now, but eventually you might see it in GI biopsies, right? I mean, so there'll be other things coming down the road eventually. It's going to result in less payment for no less work. Is there one more question maybe, and this will be it? I think there's somebody back there. Oh, well, or...
So with that comment, in a sense, in terms of bundling going up that way, can you still play the patient care patient quality card in a sense in terms of trying to deal, or is there any option of what we've got in terms of trying to mitigate what the future may hold for us?
Well, of course, that's in a system now that's run through a fee-for-service model, right? And so if we believe, and I think most people do, that we're eventually going to get away from that in some degree, whether that's 20% or 80% of our volume, when you get away from that model, it's going to be a different methodology anyway, and so you'll end up still, you know, we have a right to provide the quality, right? I don't think the quality is going to go down no matter where the price is. We're just going to be stuck having to deal with the financial outcome.
So the fight then is going to be in the sandbox with our co-conspirators in the ACO in terms of making sure we can at least cover our technical costs, if not get ourselves paid about that as well. So the battleground will shift, is what I'm hearing you say.
Absolutely. That's why it's so important for everybody to be involved in their healthcare system. And that doesn't mean just being on the standard utilization committees like blood utilization, for instance, or sensitivity, the microsensitivity committee, for instance. We're talking about you need to be out there involved. I'm on our chronic care committee. Has nothing to do with pathology, you would think, right? But they all order tests. They all follow hemoglobin A1Cs, look for microalbuminuria, right, in these patients. There's all kinds of testing that's being done in these patients. And not having a pathologist, they were, sure, yeah, come on. Absolutely. So with that, that's going to be the last one. I do want to take one point of personal privilege. This is not on the script, but I don't get this opportunity very often, and I don't see this individual very often. And so when I was younger, I had a mentor who probably didn't really realize he was a mentor. He helped get me to where I am today. He got me more involved in medicine. I was obviously a resident at the time, but he was able to move me along to where I got involved in the AMA, the CAP, APF, state organizations. And I just want to thank him today, and that's Rob McKenna. And I believe I see him sitting right over there. So thank you. And so mentors these days are so often overlooked, and they're so important to everything we do. Everybody who's younger than we are is always looking for someone to help guide them, and it's so important, and I want to just take the opportunity to thank Rob. I want to thank our speakers. Great.